Okay, so today's case is quite an interesting case. We are slightly biased to neurological cases with neuroimaging findings for obvious reasons because it's basically a neuroimaging teaching, by the way. But it's but I think this case was highlighting, and this is really one of the cases that maybe brain scans would be really helpful to make a clinical decision whether in diagnosis or the management. So let's just thank Radiopedia for providing the resource material for the images we're discussing today. I have choose one of the cases from one of our colleagues from Algeria. So this is a 55 years old woman with a 15 years history of rheumatoid arthritis. It's a long-standing rheumatoid arthritis with a fair disease control on methotrexate. She had a difficult time to manage her rheumatoid with her rheumatologist, and at the moment she's in unfair control on methotrexate. However, due to repeated chest infections, so recurrent episodes of coughing, expectorations, and on chest X-ray follow-up, it found some background changes, a decision to switch therapy because methotrexate can carry an observable risk of infection, particularly with pneumonias, and also carries a risk of interstitial lung disease over time. So, because of the background changes, this has a decision has been made to, and also because of the fair control, her team decided to consider a biological treatment of the disease-modifying anti-rheumatoid drugs. And in this case, it was a TNF alpha blocker, infliximab. Uh, so she had continued well for the first 6 months of her therapy, better rheumatoid arthritis control. However, over time, she started to lose weight and she became anorexic. Uh, Over the last several weeks, she became lethargic progressively, and which tend to get worse over time. Sleepiness increased. Appetite also is not at its best. Um, and she presented to the emergency the department of your hospital following a development of a new onset seizure. It was a GTC in nature, there's a description, 2 minutes, slow recovery of consciousness. Again, repeated for a second time at the emergency department. So she was loaded with anti-seizure medications according to the local protocol of the hospital. And she had been slowly recovering since then. And you have been asked to have a look on Our Lady, and which still a bit lethargic at the time of examination, but it was little more responsive. But she was able to give some history as well. She reports some headache. It's mild, no peculiar character. She denies any visual symptoms, double vision or otherwise, and examination is unremarkable. So this is a context of a patient who is otherwise normal apart from having an autoimmune condition, rheumatoid arthritis, and on a biological treatment or an immune suppressive, broadly speaking, if we can say. And she presented with new onset seizures. So this is a context of seizures in the context of an autoimmune condition or on the context of an immune suppressive therapy. And that's her initial blood. So she had a raised white blood cells with neutrophilia, something you wouldn't be surprised if after following a couple of seizures, but her ESR was 120, CRP was 34, liver function test, urea were unremarkable. Her initial CT was suspicious for focal white matter changes. So a further MRI has been arranged accordingly. Going as usual, we will go through the images first and maybe discuss the decisions based on that. And at the end, we will just confirm a diagnosis and maybe go through the teaching points from the scan. So this is the flare sequence starting from the skull base and maybe the posterior fossa upwards. So I'm going to slightly go up. Okay, so that's almost a flare. Of course, a terrifying looking flare. Yeah, I prefer not to speak, Professor Ashraf. Okay, so that's a terrifying looking flare. What if anything really grasped my mind on seeing this scan is what how this lady has been previously normal before the seizure happens. So it's a terrifying appearance actually. Let's have a look on the T2 for one good reason, but yeah, but we will go through that again. Okay, so that's the initial MRI performed at the emergency settings, and that's her diffusion, which largely does not show most of the florid white matter problem in the supra and infra tentorial compartments. Okay, so what would you like to do next in this context? So you are faced with a patient with a new onset seizure, um, and an MRI appearance with this extensive white matter involvement. And so, what's your next step? What's your next decision to take? Okay, Dr. Yasser is commenting about an enhanced scan. Yes, that's absolutely fine. Professor Ashraf is commenting about CSF. Absolutely necessary in this context. Um, Smartly, Dr. Yasser also is commenting about CD4 count, assuming that there might be a problem with acquired immunity, so of HIV settings, for example. It is very sensible given that in the history of repeated infections and the background changes, because this can happen with pneumocystis jirovecii or pneumocystis carnii, the older term, which is something that makes you would like to at least rule out HIV infection. That's very concerning. Yes, and CSF examination, Dr. Muhammad is saying as well. That's sensible for one good reason. One good reason: any patient at risk of immune suppression and presenting with neurological problem warrants an exclusion of CNS infection. This is a golden rule and shouldn't be overridden by anything else. This is in a context of any immune suppression. Immune suppression can merely be age, just age. A geriatric patient can merely be a diabetic patient, can merely be a patient on an immune suppression, can merely be on other signs of immune suppression, such as repeated infections, even in the context of 55 years old and otherwise unremarkable history. Uh, PML is a consideration. Yes, why not? So we as by the heart of a neurologist, we are quite and physicians actually. So we are concerned about infections at this level, and this is needed to be ruled out sooner than later in an emergency setting. So this might be at the end of the day might be any other sophisticated diagnosis, but before starting to rule out any other problem, we would like to reassure ourselves that this is not an infection. And in this context, in this particular context, I would rule in out infection with a CSF examination. Next comes the MRI. The contrast enhancement is really helpful, and the rest of the bloods like CD4 counting, HIV testing, body scanning, but would be also be helpful. But at this stage, a CSF is really warranted. That's her CSF examination results. Opening pressure 34, and physical aspects not particularly concerning, but the protein was 900 milligram per deciliters, 300 lymphocytes. Very reassuring towards a certain infection anyway. There should be an infection given the cells, protein, and the consumed glucose in the CSF now. And that's how her CSF post-contrast T1. Okay. Um, I think the post-contrast particularly is very, very helpful in this context. Of course, the CSF examination is quite revealing as well. But what's your next step? So you should be one step at this stage. You should be one step apart from making a diagnosis. What's next you would like to do? Okay, Dr. Yes is saying miliary TB on top of the list. Okay, so what you would do to make a diagnosis of TB or not making a diagnosis of TB? MRS is not particularly helpful because I would say MRS is very answers very limited questions in our clinical practice overall. But so MRS, I would think that this would discriminate between an infection and or an inflammation versus a neoplastic process. For a neoplastic process, I would start with whole body scanning, tumor markers, and obtaining a biopsy before if on these contexts if these contexts are quite limited or unattainable, I would think of MRS. Technically, also, all the lesions appear small. Maybe the thalamic lesion would be really helpful to make a conclusion with MRS. However, um, so we always ask the MRS the question that is most difficult for the MRS to answer. What I mean to say is that sometimes we are in confusion between a high-grade infection or inflammation versus tumors. Both appear the same on the MRS. So this usually when you need the MRS is very difficult to get your question in. Dr. Yasser Al-Kanash is commenting on PCR. Which PCR? So which type of would it a viral PCR? Would it yeah, of the CSF for what? For that's what I mean. Which organism are you suspecting? PCR for TB. Yeah, yeah, yeah. That's exactly. Thank you for that. I just want to make that clear. So say yeah, a gold standard to diagnose an infection is to get the bug under the microscope or part of the antigen or part of the DNA. This is how you make a microbiological diagnosis. So any infection diagnosis is made by obtaining a part of the virus or part of the organism. So for this case, it's either you see the TB bacillus under a microscope, either you culture that, either you see the PCR, and PCR is DNA testing for that. And this rule applies for all types of infection. Any infection you would like to see, you would like to confirm its presence, you need to see it. So sometimes we can see it by proxy. So for example, when you find an antibody against it, but this is still not the gold standard to do it. It's the gold standard for any infection is to get the PCR done, is to culture it, is to find an antigen for it, and of course to biopsy. So I think one of our colleagues mentioned the to do a biopsy. This is a good next step if the fluid biomarkers were not helpful. But I would start with obtaining a PCR of a TB in the spine. And importantly, really, really, really importantly, to get a very large CSF sample to get this done, a minimum of 5 mils. If you would like to confirm a CNS TB diagnosis, the yield of the CSF positivity is low, and it's reported to be low as 60%. So it's approaching a one-to-one chance that you get it positive or negative in an already confirmed case. Again, for the GC virus, would be the case to make a diagnosis. You would need the GC virus PCR. It makes sense to think of PML in the context of immune suppression. However, the imaging appearance are not particularly typical of it. So it's the imaging appearance has been pointing towards one type of for example, TB is really sensible to look scrutinizing for that. And even sometimes it's even easier to get the biopsy or get the TB uh, elsewhere from the body rather than from the CSF or the brain. So, if you have an abnormal chest X-ray, was this case has been which has been the case for this patient, you may want to have a sputum culture, and you may want to have, even if for biopsy, you may take it from one of the lymph nodes or one of the on the lungs compared to the brain. So it is again the looking for the organism itself from a different part of the body might be easier at some point, and might be more yielding more diagnosis. So if you overall respiratory sampling and biopsying can be more diagnostic, has a yield of diagnosis overperforming the CNS compartment. CNS compartment is low has a low diagnostic yield. So what does it mean is that you can get a biopsy, you can get the CSF, but you would not get a positive finding despite that it is the very TB bacillus causing what's going on. So this case, yes, this is a case of TB, CNS tuberculosis, and so I'm showing the scan after following 6 months after confirmation of a diagnosis, and starting anti-tuberculous treatment. This is the imaging appearance, and that's her post contrast. Marked improvement after 6 months, but still there are some findings. So the diagnosis of CNS TB or any TB again lies on the microbiological diagnosis. Here, the teaching point that images can narrow or focus your differential diagnosis. However, you don't make a diagnosis based only on the scans. So the scans are really florid, but and can be quite suggestive for the reasons we are going to discuss in the next few minutes. However, you cannot confirm a diagnosis without a microbiological evidence. And in this context, we would like to go to with the CSF examination or a CSF PCR for TB and examine for interferon radioassay. It's called the quantiferon testing, or getting a sputum sample. But among the list you would like to do, I would agree with Dr. Yasser's that I would screen for HIV. I would screen for neurocystic sarcosis. I would screen for syphilis. I would screen for the full list of potential opportunistic infections that can approach this particular patient. Okay, so Isra, is a question in view of clinical background and the MRI appearance, what about the toxoplasmosis possibility? I would include the toxoplasma antibodies in the testing. However, it's not particularly impressive of toxoplasmosis. There are some features that may look like, however, it's not the complete features of it. So let's start by having an idea why the images are suggestive of TB. And in retrospect, we will discuss why the other potential options are not attainable. But let's focus on the typical one of the typical appearances of TB in the MRI brain. So the first thing is the appearance of the lesion. So the on the flare and the T2, the edema has been maybe hiding some of the lesions, or at least the original appearance of the lesion or the core of the lesion. However, in the post contrast, it was very, very revealing that you have a small micro abscess. That's what it takes. I'm not sure if the marker is there. If I'm able to let me try and see if I can use a pen. So let's focus on one of that. So this is a micro abscess. This is an abscess with a wall that is enhancing, and within the wall there is an early cavitation. feature that is very, very, very limiting you in your radiological differential diagnosis. So this appearance happens in very few differentials, particularly when they are miliary, when they are multiple, like this case. So the most common is the neurocystic cirrhosis. The neurocystic cirrhosis is the image on the right-hand side on the T2. You can find that there is a cyst likely or something with a wall, even in a T2 without the post contrast, and there is an inside of hypointensity. This is called a cyst with a dot. And again, this is miliary happening in plenty of sites and all of the same size and follows the same rule. Looks like a target. So an outside hyperintensity with an inside of hypointensity. The very distinctive feature in this scan, and why I wouldn't encourage to say that this is neurocystic psychosis at all, is that we had an initial CT scan, which I didn't show, but it was showed hypodensity. It is very easy to pick neurocystic psychosis in a CT scan because these dots are actually calcifications, and you can easily find some calcified cysts for the neurocystic psychosis. Unlike TB, CT of this patient, the CT of this patient was normal, or at least not showing hyperdensities or calcification. It showed hypodensities reflecting the edema surrounding the lesions. So the first rule of thumb to TB tubercles appear as microabscesses, small granulomas that early cavitates and leave a hypointensity on the post-contrast T1. Let's go back to the case and see how they do appear in the flare and then on the T2, because T2 is really helpful in making you of that suspicion. In the flare, it is the edema is really florid, so we couldn't point out what's going on. But as you can see, this is the lesion, the core lesion with the edema, and also with the hypointensity in the middle, which is the TB caseation, the cavity within the small TB. So again, you can find it in few lesions, but not particularly all the lesions. Again, here, this is, you can see it, you can appreciate that, but not particularly in every single lesion, unlike the CT, the post-contrast T1. Again, here, there's another one. So at this point, I would be really alarmed. I've seen suspicion of what looks like 3 to 4 tubercles in the on the flare. So what I would do at this point is that I will jump to the T2 because the hypointensity within the lesion are more likely to be seen in the T2. Here's one easier to be seen, and the second, and third, fourth, fifth, six, sevens. So here's a hypointensity even before going for a post-contrast MRI. Still, more and more become more suspicion. Here is a very looking like target lesion, and another one here as well. So this looks like a target lesion. Target lesions have a very limited differential. The cyst with a dot, neurocystic psychosis, you can easily get this diagnosed very reassuringly by a CT scan. So if you had this in MRI and had a CT scan and you found a calcification, bingo, you got a diagnosis. For the TB, you wouldn't see the case. Miliary infections, any other disseminated infection can happen to have that to some lesser extent, but it's still, this is not an absolute biomarker to TB, and there is no other differential. So for example, if you had any disseminated granulomatous disease, you may have these tubercles or granulomas that might appear the same, maybe not as florid, but your diagnosis would not be solid until you make a diagnosis. Again, you make a diagnosis through a microbiological diagnosis and not only the radiological diagnosis. So that's the pattern number one, or the appearance that I'm keen to discuss with you. So here on the post-contrast, look at the scans. Almost all the lesions have this pattern of the target sign: small abscess with microcavitation, small abscess with microcavitation, all through. So that's quite interesting. This is very consistent pathology here, and all of them shows this micro early cavitation. This is a miliary TB appearance, a typical appearance of a miliary TB. So that's our first feature, it's appearance. What is the lesions on the scan? Not clinically, but what is the lesion? So this is how the lesion is appearing. This is appears like a micro abscess. And the second important feature is where is the lesion? Is the distribution of the lesion. Any blood spread pathology. So in the blood spread pathology can be infections, can be microemboli, can be metastatic seedings. So any pathology, any foreign something traveling to reach the brain through the blood has a particular distribution. There is an anatomical fact on the blood supply. So we have to supply the cortex. So some vessels come from the surface, and some vessels come deep from the white matter. There is a form of arterial nipping or narrowing to when the arteries travel through the cortex. So the average diameter on the white matter or the average diameter on the surface of the brain is larger than the arterioles or the small arteries supplying the cortex. And this is a site where a tiny embolus, a tiny TB seeding, a tiny metastatic deposit would be entrapped. So it is any hematological spread is likely to be trapped at the gray-white junction. Gray-white junction applies to the cortex like these. So if you compare all the lesions we can see on these are all trapped in the cortical mantle in the gray-white junction. Okay, so all these lesions are trapped in the gray-white junction because of the arterial nipping, the narrowing of the vessels as they pierce through the cortex, either from the deep supply or from the surface supply. So all these are trapped. So there is a pattern here. So this is not random, and this pattern also still persists in the gray-white junction of the deep basal ganglia. So you will find some lesions that happen through the junction between the internal capsule and the head of caudate, and the thalamus and the internal capsule here as well. So you may still find deep tubercles here or granulomas, but they are trapped at the gray-white junctions. Let's apply this pattern on the scan we have. So let's use for our own purpose. It's easier to see it on the cerebral hemispheres than in the posterior fossa. Brainstem, there is no clear gray-white junction, but in the cerebellar hemispheres, these are trapped infectious seedings, and they are all in a gray-white junction. This is again a gray-white junction because this is a dentate nucleus. As we go up, gray-white junction, gray-white junction, or cortical white matter junction, cortical white matter junctions. They're all here. They are all cortical white matter junctions, and even in the calcarine sulcus, they are all gray-white junctions. So there is a pattern here. So this is a distribution of a problem that is likely has came through the blood. So this is a seeding pathology. Seeding pathology, you're rightful to think that this is metastasis. You're rightful to think that this is an emboli. However, the context is different and the contrast enhancement is atypical, but you might find this pattern in a diffusion restriction pattern and dots of hyperintensity in a diffusion restriction in a completely different patient, and you might find showers of atrial fibrillation or showers of fat embolism from a fracture in the trauma patients. So this is a pattern that tells you that this is something traveling from the blood. So this is what actually makes you highly suspicious of seeing on suspecting TB in this particular context. But before the scans, you have a strong suspicion of infection, broadly speaking, because this is a lady on immune suppression, tried multiple immune suppression, and she had a history of recurrent infections in the chest. You have also a very, very particular concern with tuberculosis, with TNF alpha therapies. TNF alpha blockers are known to exacerbate latent TB, and it is inherent part of the protocol of pre-screening prior to start any of these treatment options. JAK inhibitors, TNF alpha blockers, are particularly concerning for TB exacerbations. Uh, and it is a rule that you rule out by clinical examination, history taking, and tuberculin test or interferon gamma assay before starting these treatments. However, people with latent TB can have a negative tuberculin and can have a negative interferon because the sensitivity and specificity is not very, very bright in these tests. So you can still have an reactivation of TB, but there is a clinical pointer. There was a clinical pointer here is that you need TNF alpha blockers are very, very concerning regarding TB, in particular TB diagnosis. TNF alpha is one of the cytokines that is important in containing the infection and promotion of the granuloma formation. If you lose that, patients are at risk of spreading the infection, like in this case. So there are other features for TB, CNS TB. They were not there in our case, but however, there are some TB can have with other appearances. And actually, it's more common to appear with a TB, with the meningeal reaction or meningitic type of TB. So this is a patient with a TB meningitis. This is a post-contrast T1 on the right side, and it's particularly enhancing on the basal meninges, typical of the TB. Sometimes it can also appear on the spread throughout the brain, not necessarily in the basal meninges, but because the caseation and the reaction is more predominant and it is heavier in terms of gravity, specific gravities, they tend to be localized on the basal part of the brain. So this is, as Professor Ashraf is commenting, this is a meningeal enhancement. This is a LIP2 meningeal enhancement. LIP2 meningeal is a form of enhancement where the meninges surrounding the sulci and gyri also enhance. And this is pattern number one. Pattern number two is to have a pachymeningeal enhancement, which the enhancement follows the dura, but not particularly the sulci and the gyri. Both are well described in TB. These are two cases of TB. So it's just can be pachymeningeal, can be LIP2 meningeal, and can be parenchymal as our case. And actually hydrocephalus, yes. So for the previous case, we had both cases has obstructive hydrocephalus or communicative hydrocephalus, actually, because the subarachnoid space is filled with caseation and inflammatory reaction. Of course, it can present with a tuberculoma, which is a larger form, of TB caseation. So, and here in this case, it looks like an abscess anyway. And this is a leptomeningeal enhancement beside the tuberculoma, the larger tuberculoma. And Dr. Yes is asking if is there any differentiating sarcoid from granulomas, from other forms, infectious granulomas? And the simple answer is no. No, you shouldn't rely on that. So you would rely on making a diagnosis, either a biopsy or a microbiological evidence. So I would say, so to go for the CSF, and if the CSF is non-revealing, so it is either a TB with a negative test or a sarcoid, and in this case, I would biopsy the dura or the leptomeningeal space, or even the parenchyma of the brain if I can do one. And before that, the diagnosis is not solid, actually. Okay, so let's speak very in the next few minutes just to about the risk of opportunistic infection following anti-TNF alpha therapies. In this case, so the overall risk is high, but is particularly very high in tuberculosis. Other infections are possible, herpes types of viruses, candidiasis, and oropharyngeal and esophageal candidiasis, among other infections, but particularly TB is concerning in this context. So the risk of immune suppressants, I'm just copying the relative risk ratio for the common ones we use. For the cyclophosphamide is quite high, it's tripled to a placebo or to a patient not receiving cyclophosphamide. It's triple risk. TNF alpha is 2, steroids is 2.5, even more. But that's a very wise moment to remember that we always use steroid sparing drugs, the azathioprine and methotrexate, compared to the steroids merely if it is just for dodging the high risk of infection on the steroids. It is enough on its own. However, we know that it is for plenty of benefits to use one of the steroid sparings compared to continuous dosing of steroids. So let alone a patient who is in a continuous low dose of steroids, being myasthenic, being lupus, being rheumatoid with a continuous low dose of steroids, these are a very, very high risk of developing an infection at some point. And the comparison of safety profile of these different two treatments, it makes you willing to start with a conventional disease-modifying anti-rheumatoid drugs compared to any biological, compared to any other biological therapy, because if you can control it, the risk profile is really quite limited. Okay, so this is just a reminder how to treat tuberculosis of the central nervous system. So you have two phases: an intensive phase of 4 anti-tuberculous for 2 months. This includes the 3 common antimicrobials we know about, INH, rifampicin, and pyrazinamide, plus a fourth agent. Usually in the pulmonary TB, you may use ethambutol. The problem with ethambutol is that it is not a CNS penetrant, so you would like to use a different agent to treat CNS tuberculosis. And another reminder is that it needs to continue for a minimum of a year. So unlike the pulmonary TB, which can be a few months shorter than that. And there are other few considerations. So there are some emerging resistance strains of tuberculosis. This is, I think, beyond our specialty, and we need to at this point we would involve infectious diseases team or respiratory team. They know how to deal with drug-resistant TB and to pursue the tests to see how sensitive the medications are being used. And importantly, we need to use steroids for 6 to 8 weeks. For one good reason is that the initial treatment of CNS TB is associated with worsening of symptoms and radiological appearance. And this is a condition called deconditioning. So once the TB is exposed to the immune system, there is a florid inflammatory reaction against that, and edema tends to increase. And in an ideal setting, people with CNS tuberculosis start their anti-tuberculous as an inpatient with under observation, because the risk of deconditioning, worsening of symptoms, is quite common. And it's ideally to happen anyway. So you would like to give the steroids, dexamethasone ideally, and with a weaning dose for 6 to 8 months, as per the previous slide. But you would continue to keep your observation, because there is a risk of developing a hydrocephalus once you start your anti-tuberculous. There is a risk of extension to the pituitary and causing hyponatremia due to SARA, and there is a risk of also paradoxical extension in the subarachnoid space. For example, this is one of the described cases of optochiasmatic arachnoiditis, which is basically a meningitic process, but it extends around the optic chiasma and the pituitary, so it causes hyponatremia, and it compresses and this had a dysfunction at the optic pathway, visual pathway level, and can contribute to blindness. This is a paradoxical worsening. So this is a patient prior to treatment, and this is after treatment, and not the other way around. And this is a patient with the optochiasmatic arachnoiditis. So as you can see, this is the optic nerve, and there is an extension of inflammation. Sometimes this, as a part of the paradoxical worsening, is to extend to this area, which is very, very sensitive. And of course, you can appreciate there is a massive hydrocephalus happening here. Okay, so to this point, I would conclude. And if there are any further questions,